talk more about how we manage biological exposures in our workers. When we think about managing biological exposures, we have to remember the healthy worker effect, right? Our workers are typically less susceptible to disease than the general population because they're able to work by definition. And this is a kind of selection bias. One of the things I sometimes hear in our farm worker workforce is that there was someone else who started on the job and left very quickly because they got so sick they couldn't keep working. Potentially from exposures to things like endotoxin or just the total organic load, or maybe novel biological exposures they hadn't had before. And so that means that when I'm looking at these workers, they are the ones who have been selected to stay in the workforce and therefore probably have lower susceptibility. But that doesn't mean we don't have vulnerable populations within our workforce. These are groups of people at particular risk. And when we are thinking about infectious disease agents and other biological exposures, there are quite a few biological host-related factors to consider. So age is very important in terms of immune development, or in an older workforce, what we call immune senescence, that the immune system is just not firing on all cylinders. It's having a little trouble, even with more common infectious agent exposures. We recognize there can be gender-based differences in susceptibility. Certainly with Campylobacter, we tend to see it more in males. And there may be differences with influenza in terms of what you see in males versus females. There are genetic factors, such as people who have sickle cell trait may be more resistant to malaria. And then, of course, pregnancy can cause changes in the immune status, as well as be a specific window in terms of the development of the fetus for susceptibility. So 2 examples of those would be Zika virus and microcephaly in the fetus, and Toxoplasma gondii and the window of susceptibility for neurologic outcomes in the fetus. There also are other extrinsic or exposure-related factors. Often nutritional status can influence just how robust our immune system is performing. Geographic location may influence especially those vector-borne diseases. And we recognize that socioeconomic status may also have other links in terms of proximity or in terms of opportunities for other kinds of exposures. Certainly comorbidities, such as other diseases, can impact susceptibility, for example, through changes in barrier function. From an industrial hygiene perspective, we think about ERIC as a decision-making framework, right? This is how you anticipate, then recognize, evaluate, control, and confirm your hazard mitigation strategy. So the first step is to be aware, right? And then you anticipate and recognize the hazards. You evaluate the exposures, and then you go in to control the exposures, but confirm the protection from the risks. And then this goes into a feedback loop of communication and changes in prioritization based on any changes within the workforce that feeds back into that anticipation and recognition of hazards. And this applies to biological exposures as it does to chemical and physical exposures as well. Unfortunately, there are a lot of different kinds of exposure standards in occupational health, but not that many apply within the context of biological exposures. And so, we don't have a lot of recommended exposure limits from NIOSH. We don't have a lot of permissible exposure limits or PELs from OSHA. We do have some threshold limit values or TLVs from ACGIH. And, there may be some guidance on, wheels or workplace environmental exposure levels from AIHA, but again, there just are not that many. If we think about biological stressors, a lot of these relate to either allergens or certain kinds of dust that have particular importance in terms of specific health outcomes. And so here we have some threshold limit values, right? For cotton dust, flour dust, grain dust, and wood dust. In terms of regulation of microbes in air, there are some maximum safety levels for indoor air, but one of the issues is that not every bacterium is created equal. And so if we say it's, 10 to the third colony forming units per meters cubed, then that may not matter if the possible internal dose or inoculation dose of a particular pathogen is only 10 colony forming units. So certain kinds of E. coli, you don't need very high exposure. Norovirus, you don't need to be exposed to very much. And there are other pathogens where that's true. And so this maximum safety level is really just sort of a general guide and certainly doesn't apply within a lot of the farm or animal occupational settings. It's important to recognize that there may be work restrictions for infectious personnel. So people who have hepatitis A or measles or SARS-CoV-2 or even Staph aureus, as well as enteric pathogens, you may have a work restriction of variable duration. I'll use SARS-CoV-2 as the example here because the work restrictions are quite variable. Primarily, the guidances are focused on healthcare workers, and it also is often dependent, right? So it's not just when you had symptoms and a positive test. It can relate to severity or other factors that could influence viral shedding, because usually with SARS-CoV-2, one of the concerns would be that you are infectious to patients who may be susceptible. And so again, where you're working, how you're working may be influential. But one of the things I think is important to remember is that when we consider our NIOSH hierarchy of controls that we very typically apply to chemical exposures, we may also think about physical exposures, can be applied to biological exposures. And so at the most effective level, we might try to eliminate the pathogen source. We could potentially do some substitution, although I will say that is trickier with infectious agents. But there may be ways it may be possible to substitute something that is of lower allergenicity. Where we tend to focus a lot, and these, again, are often operationalized best in healthcare settings or in laboratory settings, is in engineering controls. So thinking about building materials with antimicrobial properties, you think of biological safety cabinets as places where you might work with infectious agents. You might think about no-touch decontamination strategies or advanced disinfection technologies. Administrative controls can include more hands-on manual cleaning, can also include contact isolation, other hospital hygiene protocols, and then, of course, our personal protective equipment, use of PPE and personal hand hygiene. With SARS-CoV-2, elimination might be stay-at-home orders and social isolation, which unfortunately doesn't apply to our essential workforce. But with engineering controls, like changing ventilation or using physical barriers. With administrative controls, work from home strategies or staggered schedules. And then, of course, with PPE, using our N95 masks, gloves, and other face shields are all part of different strategies used for SARS-CoV-2.